Neurology Quiz number 16. What is the Tolosa Hunt syndrome? This is a rare cause of painful ophthalmoplegia and is thought to result from idiopathic non-specific inflammation in the region of the cavernous sinus and/or superior orbital fissure. Symptoms consist of periorbital or hemicranial pain combined with ipsilateral cranial nerve palsies. The third nerve is the most commonly involved, followed by the sixth nerve, fourth nerve, and ophthalmic division of the fifth. The oculosympathetic fibers may be involved. Rarely, inflammation can extend to the orbital apex and affect the optic nerve. MRI brain with contrast and with coronal views is important for diagnosis. It reveals thickening of the cavernous sinus due to presence of abnormal soft tissue that enhances after contrast. It is to be emphasized that this condition is a diagnosis of exclusion, and differential diagnosis includes carotid artery and other arterial aneurysms, cavernous sinus thrombosis, neoplasms such as pituitary tumors, metastases, orbital infections, and conditions such as sarcoidosis, among others. These are excluded by comprehensive workup, which includes MRI, angiography, laboratory tests, CSF examination, etc. The condition usually responds very well to steroids, which are started in a high dose and then tapered to a low maintenance dose as the patient starts improving. Treatment may be required for weeks to months. Relapses can occur on stopping treatment. What are the features of sporadic inclusion body myositis or IBM? This is a slowly progressive acquired muscle disease, most common after age 50, with unique clinical and pathologic features. There is a preferential involvement of the quadriceps, finger flexors, and ankle dorsiflexors. Early symptoms are difficulty standing from a chair, knee buckling and falling, grip weakness with difficulty manipulating objects, as well as swallowing difficulty. Muscle involvement may be asymmetric. CPK elevation is usually moderate, less than 1500, and EMG can show mixed myopathic and neurogenic changes. Antibody to cytosolic 5-nucleotidase 1A is detected in 40 to 60% of the cases. Muscle biopsy shows inflammatory changes with lymphocytic infiltration and degenerative changes reflecting impaired autophagy, and these changes include rimmed vacuoles containing amyloid, as well as aggregation of proteins like TDP43 in the sarcoplasm. There is no treatment of proven efficacy, and supportive care is the mainstay of therapy. It is not clear if pathogenesis is predominantly inflammatory or degenerative or both. This is an image showing marked atrophy of the quadriceps muscle and the flexor muscles in the forearm. This is from an article by McGrath, Doughty, and Amato from 2018. Image A shows endomysial inflammation in IBM, and this is from an article by Hilton Jones and Brady in 2016. Image B shows rimmed vacuoles on muscle biopsy, which are best seen on Congo red stain, and this is from the neuromuscular homepage by Alan Bestronk. Which muscles are involved in abduction of the shoulder joint? The first 15 degrees of movement are executed by the supraspinatus muscle, innervated by the suprascapular nerve C5-C6. The deltoid abducts the arm from 15 degrees to the horizontal plane, innervated by the axillary nerve C5-C6. The trapezius innervated by the spinal accessory nerve, and the serratus anterior innervated by the long thoracic nerve or nerve of Bell C5-C6-C7, elevate the shoulder above the horizontal plane.